afternoon, everybody. Welcome again. This is the third webinar on migration health that we are running here at the WHO Regional Office for Europe. And this webinar will be on a very important topic, mental health, related to migration and refugees issue. It's organized and supported, funded by the European Commission MIGMA project, Migration Health Knowledge Management project, and we are very thankful to our donor for investing into supporting the sharing of knowledge across the region. As I said, this is the third webinar, and last one was more on advocacy element of mental health. This is for the expert of today. And we had 1,600 contacts following the discussion. And what was really interesting also, many from countries not in our region. So to show that the topic is very important, sensitive, and attracting a lot of attention for the those working in the area of migration health and those not. I would like then to, before to give the floor to Dr. Della Mata, that she's following us from Brussels, I would like to introduce the two experts that today will be running, allow me to say, the show. They will be presenting and discussing the topic of mental health on migration. Is Professor Stefan Priebe. It's a professor for social and community psychiatry at Birth and the London School of Medicine and Dentistry at Queen Mary University Hospital in London. And, but it's also, since 2012, director of the WHO Collaborating Center on Mental Health and Health Service Development. Professor Priebe was also the author of one bestseller produced by this office, HEN report, Health Evidence Report on Mental Health, which is really a milestone picturing the situation across the region. So welcome, Professor. Thank you for being with us. And then probably a colleague which doesn't need too much introduction. Guglielmo Scrina was with us already last time. It's from IOM, is the leading person for the psychological and mental health services within the IOM, but also a colleague with enormous experience around the world, been working in many countries in different parts of the world, and also a good friend and really a big supporter of the webinar, playing. And thank you for that, for your availability to play the role of moderator and stimulator for the technical discussion. I'm not taking more time from the webinar, and I'm passing the floor to Dr. Isabella Della Mata, who is the Principal Advisor at the Health Directorate General for Health and Consumers at the European Commission in Brussels. Isabel, the floor to you. Thank you.
Thank you very much, Dr. Severoni. I'm very happy to be able to participate, even if it's in the distance, in this webinar that is just one in a series that the WHO, as Dr. Severoni has explained, that we hope to continue with other webinars in this topic of migration and health. Many people arriving in the European Union and in Europe in general have suffered violence, persecution, insecurity, have lost family members, live in poor conditions and face uncertainty about the future. Others haven't suffered such a traumatic trip, but they are confronted to a society that is different to the one of origin and have difficulties to adapt. In such circumstances, very often it's very difficult to maintain the good physical and mental health. The European Commission supports and has been supporting with the member states the health and the healthcare of migrants and refugees, including their mental health. And this is one of the reasons that we decided to join the WHO in this project. The conditions which have an impact on mental health pose a challenge for the professionals concerned, as well as for the communities that they serve. Over the past decade, we have raised awareness of such issues, and a number of experiences have been shared at European Union level, including on promoting and protecting the health of the refugees. And the Commission has worked with the Member States to have implemented targeted actions under the European Union Health Programme and includes collaboration with the WHO and the International Organization for Migration. This webinar on mental health is one in a series, as is one also in the several activities that the European Union will be doing around refugees and migrants and mental health. Recently, in the coming months, a project to develop training for health and other professionals to identify the mental health needs of migrants will begin. Also, we hope with the collaboration of IOM and WHO. So, welcome to this webinar. Have a successful and nice experience, and thank you, WHO, Dr. Severoni, and the two speakers to be able to be present today and interact with you in this webinar. Thank you very much.
Thank you, Dr. Della Mata, for your kind introduction, also giving an overview of the large commitment of the European Commission towards mental health activity, and thank you again for supporting the webinar. We truly believe in, and we are observing this to be a very cost-effective instrument to outreach a large audience of colleagues and experts and interested people. So not taking more of your time, or the time of the webinar, I'm passing the floor to Guglielmo, to you to pinch a bit our guests in interested in a hot discussion on mental health.
Thank you. I have my own microphone, so that's not needed. And I would like to introduce the subject a bit like last time, looking at some definitions, what we are talking about. This webinar is particularly dedicated to the public health aspects of the mental health for migrants. What is public health for the general audience? It's the science and the art of preventing disease, prolonging life, and promoting human health. How? Through organized efforts and informed choices that regard not only the individual or the services, but really the society, different organizations, communities, and individuals. How do we found our job in public health? Through the identification of threat to health through population health analysis. That's the foundation of our work. And then from there we develop in organizing, as I said, efforts and making people produce informed choices on all these levels. Why therefore public health or a public health paradigm becomes a bit difficult to apply when we talk about mental health on migrants? Because who is a migrant? A migrant is, according to the IOM definition that is now shared by most agencies, any individual who has crossed an international border or has moved within a state away from their habitual place of residence, regardless of their legal status or whether the movement was voluntary or involuntary, the reasons why people moved, and the duration of their stay. I would also add at this point that regardless of their socio-economic conditions, because there is a tendency in the last years and in the last period to consider migrants, the discourse on migration regards only the poor migrants. We don't consider the ones who move for academic reasons, international civil servant migrants anymore, and everything that we say about migrants is about poor migrants. So there is an issue of poverty, class, they would have said, some years ago, that probably should be considered. Why I'm saying that these create problems? Because that's an enormous population. Migration is a feature of today's anthropology. We are talking about, in that definition, 1 billion individuals in the world. One fourth, 25% of those are international migrants, so migrated crossing international borders. Only 0.3% of the general population is the one of refugees. That is around 10% of all international migrants. So we cannot reduce the discourse on refugees that somehow is a population that you can study in its evolution and its development, also longitudinally, but we are looking at populations that are very diverse, from, as I said before, academics to that go to teach in another university, to victims of trafficking, from actually refugees and asylum seekers to irregular migrants, and those are very different populations, people that come from a variety of countries. So the public health discourse of analyzing, where everything is based on the analysis of a health threat in population, it's very difficult because we are talking about an enormous variety of populations. And on the other side, there is this approach that instead want to simplify things and consider them like an unicum, migrants, which becomes extremely difficult to do and ineffective in a public health paradigm. Then we are not talking only about health, but we are talking about mental health. And what is mental health? I quote again the WHO definition of mental health is the capacity of an individual to withstand the normal stresses of life, to work productively and fruitfully, to be able to make a contribution to his or her community. And all this multiplied for all the migrant categories, multiplied for all the public health concerns that regard organizations, society, community, brings to a very complex situation that needs to be analyzed and probably needs to be broken down. We cannot really talk about the mental health of all migrants in a public health perspective, but we should probably start looking at more specific categories, at what works and what not, and how to define populations in this paradigm. Knowing also that mental health is culturally bound, so our paradigms of mental health, symptomatologies, to be more precise, might not apply or might not be recognized as valid by the populations we are working with, because their cultural paradigms might be different from ours. And that's also a complication in a public health paradigms. That doesn't regard only how we translate our paradigms into theirs, but also how we accept their paradigms into ours. And we are starting looking into this complexity, thanks to Professor Priebe, that will give us an insight on the main issues, both epidemiological in terms of responses, pertaining the mental health of refugees, particularly refugees, asylum seekers, or particularly vulnerable migrants, as he will explain better. This is a lecture form. It will take around 20 minutes. Then I will complement with some information about other categories of migrants, but we want also your contribution. So for me, it's quite important for all of us that you interact with us. You can do it from home, and maybe we can go to the next slide. I can govern it. Thank you.
That was very
How to pose questions on the line. So if you are online in this moment in front of your computer, you should see this screen. There is a box at the bottom of the page. You have to click on the box, enter your question, and then please make sure that you that you press send, otherwise we will never receive it. You can do the same from the room. So if you are particularly shy, or you want to pose a question that is extremely provocative, and you don't want to be identified, you can do it looking at this. So you can go to www.slido.com, enter the event code, which is #KHHM, and then you can do the same, submitting your question. You can also tweet on #MigrationHealthWebinar. Some things that are good to know for all of you. These allow you to submit your question anonymously, so we will never be able to reach you, to ask for explanation. Feel free to submit questions while the session is running, because we are able to collect all the questions and account for them at the end. Similar questions will be grouped automatically by the system, but also the WHO team will help me in doing that. So we'll group the categories of questions, the mega theme of the question. But you can also choose among the questions that were already done, the ones that you agree with, that you would like to see answered. And you can do it clicking the thumbs up icon, both from the floor and from home in the system. Or again, you can tweet at #MigrationHealthWebinar. A last information for those watching online. There are 3 questions that will appear during the webinar. This is a sort of evaluation, feedback that we want to receive from you on the webinar itself. So please answer, because this will be very helpful in informing future initiatives of the sort. And now I leave the word to Professor Priebe.
Thank you very much. Yes, good afternoon. As has just been indicated, I will try to give an overview over the subject, and then later maybe that is an beginning for discussion. So, mental health care for refugees, it should show there, it doesn't. There we are. For refugees, as it has just been explained, migrant is a very wide term and includes a number of people, including myself, including the chair here, and most of the people in this room. I will use refugees still as an umbrella term, but basically for three groups. That's a group of refugees who have an official refugee status. So there's an official status that is defined by the UN, and if you can get accepted as a refugee in countries. On the way towards it, you need to ask for asylum. So I will include the asylum seekers, but also those who arrive in countries and don't manage to seek asylum because they are victims of trafficking, or they for other reasons. So they end up as undocumented or regular migrants. This umbrella term for refugees is how the media and how the public uses it. When we discuss, what do we do with the refugee crisis, we rarely mean refugees with an accepted asylum. We mean this whole group. So that's still 65 million in the world. Roughly a third of them are in high-income countries, and a third of them, roughly, have accepted refugee status. So there are challenges and there's good practice. Let's start with a challenge, and I will go into each of these issues in a minute. So there are the prevalence rates. Are they higher or lower than in the host population? There are the absolute numbers of people. The social conditions that contribute to and influence mental health, barriers to accessing care, and the difficulties in delivering good care. Let's start with the prevalence rates. My salary is paid for research, so basically that's what I do. And you wonder why research doesn't provide excellent data on the prevalence rates of refugees. Now that's very difficult. Who do you ask, and how do you ever manage to get a representative sample of refugees who arrived in a country? So first, even if you know which group you are after, it's very difficult to generalize that to others. But then there are always people who you can't reach, or who don't respond. So the response rates are never ever 100% of those you want to get, and the selection bias can't be controlled for. Question is, do those rather respond to studies that have mental health symptoms because they want to show their symptoms, or do rather those respond who don't have any symptoms? By and large, those with symptoms are more likely to respond. I get to that in a minute. And then there are inconsistent methods. Very difficult to compare two groups and two studies because people ask different questions, use different instruments. The instruments were not adapted to that particular group, or the interviewers didn't speak that language. By and large, the rule is the better the method, the better the selection method, and the better the interview method. So, for instance, using interviewers who spoke the language of the interviewees, the lower the prevalence rates. That's a general line. So, but even if we take all this apart, even if we assume we would have fantastic research and the same methods and no selection bias on all groups, there's very, very high variability. There are published data on depression, for instance, varying between 2 and 80%. So you can practically forget it. Everything is there. It's almost a surprise that it's not below 0 and over 100. So everything is in it. The same for anxiety disorders. Why is that? Now, there are very, very different groups. They come from different countries, different backgrounds, even from the same country. Who decides to leave the country? Who manages to leave the country? Sometimes is it rather the strong young man who has the confidence to arrive at a different part of the world, or those who are so desperate that there's no alternative anymore. So very, very different groups. And then you've got a different context. The pre-migration stressors are different. The migration stressors are different. The context in which they arrive are very different. It's a completely different ballgame whether refugees arrive in Serbia with the only intention to get through to the country as quickly as possible, or arrive here in Denmark where most of them seek to stay for a long time. different intentions also of the host society to help them and to support them. So the conclusion is you can hardly generalize anything. It is not helpful to generalize. As already been said, there is no generalization for migrants, but also prevalence rates for refugees to generalize does not make much sense. If, however, we still do that, the conclusion is within the first 5 years, there's no consistent difference with host populations. If someone tells you, oh, prevalence rates of refugees, of mental disorders in refugees are much higher, there's no evidence for that. There's only one exception, that is PTSD. That's probably higher. However, even that is below 10%. So it's not true that the majority of refugees have PTSD. And PTSD is not the most common disorder among refugees either. Anxiety, other anxiety and depression disorders are much more common. That changes a bit after 5 years. After 5 years, and people who have lived in the new country for a long time, rates of depression and anxiety seem to be higher than in the host population. Whether that is a result of living there or a selection factor, so that those without any mental disorders have left or moved on or whatever, difficult to say. There's an association with the social integration. Again, as a rule of thumb, the rates of PTSD are mainly explained by the level of the exposure to traumatic experiences, not surprisingly. But the level of anxiety disorders, of mood disorders like depression, and of substance abuse disorders are mainly explained by the social condition in which people live after migration. So that's the host population. However, the prevalence rates for the challenge are only one aspect. Much more important is how many people are suddenly there, and whether the prevalence rates are higher or lower. If there are suddenly large numbers of refugees, of course there are high numbers of people with mental disorders. And what makes a challenge even more difficult to cope with is that that can change very quickly and is difficult to predict. And that, for instance, in Germany, the numbers of Bosnian refugees in the 90s, the numbers of Syrian refugees in the last 3 years, nobody would have anticipated 5 years before it happened. So suddenly you're confronted with large numbers of people, among whom are many with mental health problems. And there are short-term perspectives and long-term perspectives. I will get into that in a minute. So if social conditions are so important, what are they? Now, again, they vary. They vary across different countries and contexts, but also for individuals. There are those with very good skills, social skills, professional skills, who make a fortune in the new country very quickly. There are chefs of Michelin-starred restaurants who arrived from Syria just 2 years ago. And there are, of course, many others who struggle to have any form of integration. We also know that part of social conditions is social acceptance. So to what extent do we accept, do we welcome refugees? That varies, again, across historical contexts, depending on how the society sympathizes with the refugees. It also varies within societies. As probably all of you know, there are big conflicts in countries like Germany about how to deal with the Syrian refugees. Are they welcome? Are they not welcome? Are there too many? Or are they absolutely necessary to compensate for an aging population? So debates within societies. And then the question is, how are mental disorders and poor social integration linked? The question of chicken and egg. Are those with mental disorders less likely to find a job or to, after a long time, and to work? Or is the absence of any meaningful occupation contributing to your poor mental health? Probably both, but we don't have much evidence, much research evidence on that. So then the barriers to accessing care, language, always a problem. If you don't speak the language, of course, you don't understand any information and you don't find your way to services. There's also lack of information. You don't know how the system works and you're used to a completely different healthcare system. A reason why many refugees go to emergency departments, because that's something they can understand, that's accessible, although that's not the most appropriate way as we would see it in our system. And there may be a mistrust of authorities. You could say for some undocumented migrants, maybe in some countries that mistrust is justified because some services are obliged to pass on the information. So, but by and large, hopefully for the majority it's not, but still do they trust authorities, doctors, services where they have to provide all their information. And then the difficulties in delivering care. Again, language. I will go into good practice there in a minute. If you can't speak with your patient, then of course it's very difficult to do mental health treatment. People present differently. Mental disorders, or things we would call mental disorders, are often presented with physical problems in the first case. Different explanatory models. So what we would accept here as maybe stress leading to depression may not be accepted in other cultures and other backgrounds. And different communication styles. Not only that some refugees expect a much more authoritarian doctor than we are used to in Europe, but also that they would expect the family to be involved at an early stage, and that again, there's no general rule for all refugee cultures, of course not. So different communication styles. What is good practice in this context? Now, there's no secret. There's no magic wand that you just need to apply and then, well, we have sorted the problem of mental health care for refugees. But 4 points: promoting social integration, overcoming the barriers I explained, facilitating engagement with services, and the confidence of clinicians. So how you promote social integration goes beyond mental health care. The opportunities to link with the local community, that depends on overall the political climate. In England, asylum seekers are often moved around deliberately, but that makes it very, very difficult to establish social relationships anywhere. Language classes, always helpful, but sounds better than it often is, costs money, and they need to be attended, but still, it's a way to help integration. I think language can't be overestimated in its importance. I can get to that in the discussion later if you want to. Programs for converting existing qualifications. Many refugees come with qualifications, which however are not accepted in our countries, and other refugees may acquire new skills, and that also require programs. Without qualifications, it's difficult to find jobs. And then there are the community forums or peer mentorship. That relates to a general rule of refugee integration and acculturation. All refugees in the world tend to seek peer groups, so groups of similar refugees in the first instance. And they stay within that group in between a few seconds and the rest of their life. But this peer group has a very important role in the transition. And that's something that societies can promote. Barriers to care. Now, outreach or bridging services that go into the groups of refugees, that actively inform and try to establish contacts. Mental, physical, and social care should be integrated as much as possible. We may be used to the fragmentation of our services and know that for, I don't know, a cardiac problem we have to go there, for a mental health problem we have to go there, and if we need accommodation we need to go elsewhere. But this system is very difficult to play if you're not from the same country and if you lack the confidence to do that. So refugees need some integration. There are 3 ways of doing that. The broker model, so you've got one person very much at the beginning who then helps refugees to find their way around, or shared protocols, that you have got a shared way of dealing with refugees across different services. And in any case, referrals should be simplified. A simple, I get to that later. Then there's information. Information that needs to be provided in appropriate forms. So that's not brochures with 500 addresses where you can go to and you don't know your way around it. Nowadays, many refugee groups are well networked via their smartphones. So web-based information is appropriate for many, not for all, but for many. And that information is missing. Would be easy to do, but it's not there. But we also need information to clinicians. Clinicians, by and large, have no idea, for instance, what the entitlements of their patients are. So, and here's a difference that initially I said I would ignore between refugees, asylum seekers, undocumented migrants. Is very important because the entitlements vary, and clinicians don't have a clue about that. Even if they do, they may find their ways around it. We know that many clinicians bypass the hurdles that are there and find flexible, spontaneous ways of dealing with it, but they should know that. You can deliver good care. It obviously needs skills in using interpreters. Again, something in a minute. So, but there's no question language barriers need to be overcome. If a patient turns up in an emergency department or elsewhere and you can't communicate, then of course nothing can be done. However, there is no guidelines. We clinicians work sometimes we work, if we work evidence-based, we work in line with guidelines. There's no single guideline that is specific for refugees. So all guidelines that apply for good care apply for everyone. So there's no medication that would be specific for refugees that isn't good for us. So that's already important to know. People can apply their guidelines. If there's one specific thing, then dealing with traumatic memories. I said that's not the main problem. And I don't think it's very helpful to focus on that, but it is a problem, less than 10%, but still overall 9%. So how do you deal with traumatic memories? A recent systematic review identified 12 randomized controlled trials in high-income countries. The authors didn't classify a single one of them as high quality, but felt the results are encouraging for most of them, and narrative exposure therapy. There were 5 trials, so there was a best evidence, but that doesn't mean there's evidence that is better than other treatments. So all of them may have their merit. We can go into that into discussion, but we will. But, and I think that's very, very important. Refugees are not only victims. They may not be even primarily victims. As terrible as it may be, what some of them have gone through, they also have potentials. They don't have only a past to look back to. They also have a future that they might want to enjoy. There's been a term of adaptive growth. Looking back can be necessary, but looking forward, that's where the rest of the life is. And refugees are also people with potentials that can help them and can help the host societies. I hope we will go into that too. I think all the focus on trauma and the terrible past is not terribly helpful. And finally, we need competent clinicians. You can be trained in using interpreters. You need to be trained in that. That's not straightforward. It's not rocket science. One can learn that. But it's something that can be trained. I know very, very few clinicians actually who have received proper training. One should be aware of cultural differences to some extent, but knowledge about other cultures I don't think is that important as long as the attitudes are there of genuine interest. It doesn't matter whether clinicians know exactly where patients are from. They can be interesting, go, show me where you're from. We look at that, we look it up on the web. Ah, that's the area, and what is it like? But one should be aware of differences. There's always a difficult balance in services. So it can happen in services that For instance, Sri Lanka, it's not unusual that people sit in a tree to think about their life in the future. And it is possible that a person sitting in a tree must be psychotic. That can happen. But it can also happen the other way around, that someone is clearly psychotic and hears voices and what have you, and people in service are who knows what's appropriate in that culture. So that's always a balance that is difficult to find. And that can only be overcome, again, with genuine interest, not tolerance, interest. So I think the confidence of clinicians in engaging with the refugees and engaging them is central. So what is required? That's my last slide. Now, usually people start with money. Yes, some things do cost money. Language services, interpreting services cost money. Even if it is language line per telephone, it does cost. Outreach and interpreting service cost money, but not everything costs money. So the organization of service, the coordination, if all services that deal with refugees in a given district of Copenhagen or Rome or Moscow would just meet once per year and present to each other what they do and agree on some shared protocol, a lot would be achieved. Doesn't cost very much. So organization, which is linked to attitudes, and of course attitudes you can't change so easily. If there are hostility towards refugees, that's difficult to change. And there's also training that again wouldn't cost that much, to train clinicians in how to deal with interpreters and how to find their balance in dealing with refugee groups. And the training should focus not on what clinicians don't know, but on overcoming their helplessness. Very often they say, oh, we have got these groups of people from sub-Saharan Africa. What do we do? Do what you've learned to do. Do what you're good at, and that is usually the best way forward. So thank you very much.
Thank you so much. Thank you very, very much. And I remind that you can make your questions. You can like the questions that are existing. You can make questions also from home before we proceed to my presentation. It will be very short and just complementing some data regarding other categories of migrants. Now I have to juggle. I hope I won't fall from the chair, but it's something, in case you are prepared. There are common psychological needs to all migrants without categorizing them. Being it, as I said, a high-profile corporate manager or a refugee that's just arrived at shores and whose status is unknown. Yes, there are. Disorientation. All of us, in any situation, will be disoriented. Obviously, to different levels, but disorientation, because you don't know the system, you don't know the language, and so on. There are identity and role changes, because your surrounding environment change, your significant others are not there with you. You have to reconstruct relations that build your identity with other people around you. There are bureaucratic procedures for everyone. I just recently moved from Cairo in Egypt to Brussels in Belgium, and the first 2 months were all occupied about bureaucratic procedures, to be fixed, and residence permit and so on. So this regards really everyone, and bureaucratic procedures can be very distressing, as well as waiting. These obviously become extremely important for people who are waiting for their status, so the real possibility to exist in that specific environment. There are studies that associate waiting and a suspended status with actually increase in mental uneasiness. Obviously, it takes time and energies to adapt a new system of social and cultural meaning. Language is only one part of it, but it's much more than that. Sense of humor. You move, from one place to another, you make a joke that would make everyone laugh in your country. In the new country, no one will laugh, and then you feel bad, And this obviously, is a simple example, but accumulates, for migrants, especially the ones who are forced, to leave. There is a more difficult access to services. This has to do with stigma regarding certain services in certain cultures, but just, language issues, bureaucratic issues, a lot of barriers. We'll talk a bit later how even today in Europe, it's not true that all migrants have access to all the level of care, of mental health and other forms of health care. That's a discussion that we need to have urgently. there is a sense of loss. This is Professor Renos Papadopoulos studied it quite in depth. There is always, even if you are a cyclical migrant, you always miss the other place when you are, in the other place. There are confused idea and multiple idea of belonging. Who I am? I'm a Pakistani, a British person, I'm a British Pakistan. This accumulation of identities also on a community level. Stigmatization, very high from the host community, more and more. As I said, especially now that there is the stigma against the poor refugees, not the poor migrants that usually are the way to define the refugees now. And then violence and exploitation that are there in many, not all, but many experiences of migration. So we are talking about stressors that are common to everyone, but does this bring to mental disorders in all migrants? So I'm looking now at the category of all migrants, going against what I said at the beginning, that I don't think this is a generalization that can be made, but just to see what happens. Anxiety and depression, there was this study, it's quite old, done by Carta et al. In 6 European countries, comparatively, that stated that migrants, and he included under migrants everyone, including also the refugees, are 2.52 times more likely to be referred to state services for those disorders than the other population. However, there are a lot of confounders that we have to look at carefully, but what is the main point? That actually this data varies dramatically from country to country for the same population. So the problem is that this is not a vulnerability people bring with them or is part of the travel, but in fact what makes the difference is the system of reception, how people integrate and the system of assistance in those countries. Mental disorder, I'm not talking about PTSD because I think we will have a discussion soon after, are consistently in all studies, quite sound studies as well, found more at risk of schizophrenia, so psychosis, than other populations, than the resident population in many countries. This goes really from Mexican in the States to Chinese in several countries to the last study, that is quite a sound study, done with a population of 1,300,000 participants, so really a sound study in Sweden, that say that refugees are more likely to be schizophrenic than non-refugee migrants, and non-refugee migrants are more likely to be schizophrenic than resident populations. Then why so? And also there is also this data that is quite consistently coming out that second-generation migrants are more likely to develop mental disorder than first-generation migrants. Again, looking at this, we go back to the same point, that is the one of integration in the countries of arrival. Because why we think, there are Dinesh Bugra made, a few years ago, 5 hypotheses of why migrants might be more schizophrenic than the others. And in fact, all those are disconfirmed by research, but 2. One is social isolation, so poverty and lack of social supports that obviously bring you to create your own world, in many cases. The second one is misdiagnosis. Because of what you are saying, symptoms is only one paradigm to read emotional problems. For many cultures, the dominant, and I think actually statistically in the world, the dominant discourse on mental health, if you look at all the countries in the world, is not the one of symptoms, but is the one of possession. I'm possessed by someone. And by instance, if you are from Haiti, you will speak with the dead, if you believe in voodoo. And that, in a psychiatrical service in a Western world, will bring you, as you say, by default, to admission to psychiatrical care. On the other side, it's true that some of these people might have real problems that needs to be addressed, as you were saying. Victims of trafficking, it's a specific category of migrants, so I'm going now from all migrants to some of the categories for which more study existed, because it's basically at the end is our capacity to trace these people, so to follow them over time. Ottisova et al. Did a systematic review of all studies last year, of all studies produced on the subject, but they could consider only 36. They put a limit of quality, very basic quality standards to accept the study, and so they went down from 200 and plus class studies to only 36. So that tells how bad the research in general is. The variance is high, so as you were saying, but they confirm symptoms suggestive of PTSD, anxiety, depression, and particularly in men victims of trafficking, psychosis that might be also related with drug use and abuse that is very common in experiences of trafficking, because it's one of the ways traffickers use to control the victims. Detained migrants, and this is a point I'm endlessly making in these last months. Detained migrants in all the studies, different studies, are found more at risk to develop depression and consider attempt suicide longitudinally, even after 5 years from the moment of detention. Yet, as you probably know, migrants, refugees, and asylum seekers altogether in Europe are put in detention or detention-like situations. Even in very civilized countries, like the Nordic countries, people are put in identification center where they are in detention-like situations for years. And this is a public health concern. I mean, we are creating a public health problem maintaining detention centers for people who didn't commit any crime. Comparative studies, and this is quite interesting in the discourse that we were making, say that refugees are usually doing worse than irregular migrants. Yet, asylum seekers are doing worse than refugees. Interesting. Why that? This is a study, Ackermann et al. From Switzerland, that is a quite conducive experimental environment, because you can really trace almost, in a laboratory-like, situation all people. Why that? Most likely, other qualitative studies say that that's because of waiting. So while a refugee has a clear status, clear rights and obligations, while an irregular migrant knows that doesn't have those. So they start organizing their life accordingly. An asylum seeker is still waiting, for organizing their life. A wait that in Europe might take up to 3 years, which is a big number of years, for people. However, we have to be very cautious. Whatever I said in terms of epidemiology is statistically significant, but not significant or not that significant in terms of absolute numbers. So this difference is significant between resident population and migrants, but the numbers we are talking about are very small numbers, not great numbers. So numbers that can be very easily absorbed by the existing health and mental health facilities all around Europe. In general, we cannot generalize, and it is always a unique combination of life history, conditions of the present, social support, access to care, and integration assistance that really determine how much a person is vulnerable or not to mental disorder. So probably we should really ditch this idea of looking at the mental health of migrants as a need, in order for which, to advocate for which we need to demonstrate that they are more needy than us of these services, but in fact consider it a right. They have the right to mental health care as anyone of us. And therefore this brings us to the availability and accessibility of services. Are mental health services available to all migrants in the European territory? No. Because mental health services in most of our countries are located at the secondary level of care, not at the primary health care level. And yet, all migrants have access, more or less in Europe, to primary health care, but not to secondary health care, because you have to register to get those services. And obviously, if you are an irregular migrant, you will never register, because this will mean that they will be able to detect you. That's probably a discussion we need to have. So mental health care should be mainstreamed at the primary health care level. That's for everyone. And WHO is doing a fantastic job in this respect. But we need also to make sure that all migrants can access secondary and tertiary level of care, because otherwise we won't solve the problems of the one who have it. Very good example, many years ago in Waltham Forest Foundation Trust of the NHS in London, a situations where there are a lot of migrants, refugees, also homeless people. They negotiated with the NHS a special protocol so that they could offer a comprehensive health assessment, including mental health, to all people, whether they were registered, not registered, or whatever. And then they negotiated a double time for the time that each general practitioner or each doctor could spend with the client, training them in addressing also the psychological issues. So that was one. It's now not going on anymore because of lack of funding. The second issue is that migration and integration, as we said, overwhelming both of us, create major stressors, and most mental disorders in migrants are correlated with social problems in the integration phase. So there is a need, in a public health perspective, to mainstream mental health not only in the health sector, but in all sectors concerned. The law enforcement one, border guards, people that actually are running the reception and the identification center. The religious one, the security and the educational one, and so on and so forth. One example, we are starting together with the European Union, with the collaboration of all other agencies in the next few, when I say we, I mean the International Organization for Migration, to train jointly health and Ministry of Interior, so security actors all around Europe on communicable diseases and mental health issues. We are starting probably in 2 months, I think, with the actual training. But it is only one example that should be duplicated more. The third principle is that migration is a feature of today's world. And the psychopathology of migration, as we said, doesn't differ enormously from the psychopathology of the normal population. So segregated mental health care services for migrants are to be avoided. Yet, all around Europe, there are a lot of segregated mental health services for migrants, including the famous or infamous trauma care centers, that are somehow dedicated especially for migrants on the assumption that they are suffering just for what happened to them in the past and not from the problems that we create for them in the present, and so on. Fourth principle is the migrants have problem in accessing existing services. Language is only one of that. There is also a problem of outreach. I have to say that on this in Europe a lot is happening. There are a lot of organizations, NGOs that really train migrants themselves, a group of migrants, in being, as you were saying, the promoter of mental health care and access to services for the others. One very good example is the one of the ethno-medical center of the city of Hannover that work as a service center for all the other centers health centers in that region, that was even considered by the Financial Times a actually good method to avoid cost to the healthcare system and actually empower migrants in being economically productive on the long term. And this is, as I said, training in mental health care and mental health promotion resources from the migrant and refugee communities themselves. Doctors of the World, Medicine Sans Frontières started a similar program now all around Europe. The last one, and talk therapies. Whatever we are talking now about access to services means access to talk therapies or pharmaceutical one. Where I sit in front of you, that's how most of our health services are combined. So I sit in front of you and we discuss about my problems of the past or the present, maybe my expectation for the future. I wanted to read you something short that comes from a study of Solomon. Solomon is an anthropologist that studied the efficaciousness of some psychological intervention in post-genocide Rwanda, but not with randomized control trial, but going in those same communities and asking them, what do you think about what they did, what they offered to you? This is a quote from one of the service users. Their practice did not involve being outside in the sun where you begin to feel better. There was no music or drumming to get your blood flowing again. There was no sense that everyone had taken the day off so that the entire community could come together to try to lift you up and bring you back to joy. Instead, they would take people one at a time into these dingy little rooms and have them sit around for 1 hour or so to talk about bad things that had happened to them in the last period. We had to ask them to leave. Now, these are the same persons that come as refugees, asylum seekers, and migrants on our territory. So I think there is much more than the issue of language to be taken into consideration, but is the one of paradigm, not only in understanding symptoms, but also how to respond to them. What is the collective basis experience of healing, and so on. And with this, I'm done, and I think we can start probably a discussion. Maybe, I don't know if you have any reaction on what I said now, because I saw you disagreeing, which I really like, no, at certain point. So maybe we can start from there.
Yes, I was heavily shaking my head. There's a few remarks, but I don't think they are crucial. As we both agree, the discussion about the prevalence rates is pointless. So let's not go into that.
Yes. Yes, and I have a question for you, in this respect. A lot of, as we said, resources are spent to analyze if migrants are a little bit more vulnerable to mental disorder than the normal population. Yet, nothing is done, or very little, in terms of resilience factors, what makes actually migrants so resilient. In terms of service evaluation, what works or doesn't work for migrants on the territory. And the little that is done in terms of service evaluation in the humanitarian field, there was recently in WHO Geneva a meeting. I chaired one of the session on the randomized control trial that have been performed in several emergency situations to test short-term psychological intervention. I have to say that the results, even though, as you probably know, randomized control trials are at times also self-fulfilling, in their construction. The results weren't particularly overwhelming. Nana was also there. So my question is this: why we don't focus on resilience? That is something that you were suggesting to do, but also in research, not only in practice. And why we don't evaluate service? So we assume that our services will work for them as they work for anyone else.
Well. Yeah, that's a wide question. We can focus more on positive aspects. I wouldn't be too keen on the term resilience either, because resilience suggests that you are resilient against something. And again, we focus on the negative things in life, so all the terrible stressors that come down on refugees that they need to be resilient against. It comes from basically from physics and from the studying of metal. A piece of metal can be resilient against the stresses. But life is a bit different. So when I moved from one country to another, it was full of stressors, but was also full of excitement and possibilities, and that's life. And I think, to me, it's a too mechanical view of life if we focus just on the difficult stressors and against which we have to be resilient. Very often, these what we help people with in treatment have nothing to do with the stressors. I mean, all of us have gone through difficult things in life, and the way to deal with this is to forget and to move on. Having said that, I'm not denying the importance of traumatic experience for those who have had it. I mean, I founded an Institute of Psychotrauma in East London and did therapy with traumatized refugees myself for a long time. But maybe I give you one case to show what I mean, with the resources and the importance of language comes into it. When I had a patient from an Islamic culture, a teacher who was at home, a well-respected man, of course, is a dominating figure in the family, telling his daughters what to do, and also his wife, and that's how they lived, a very, very respected man. Then he was probably tortured and arrived in London, and very soon he tried to keep up his I would say macho role, but was quickly overtaken by his daughters, who spoke English after a few months, and also by his wife. So he was left at home, becoming aggressive more and more, which was interpreted as a sign of PTSD. And of course, you could have gone through the past experience with him, and I did. endlessly, but that didn't change his role in his new environment. So I think the only thing I really did at the end for this man was to encourage him and to manage to get him to learn English. And then suddenly he was out of his social isolation and could take at least a slightly different, more active role in the new society. So it's very simple things are important, and language is one of them, because it's not possible for all refugees to live within peer groups in which they don't need their language. I apologize for making one remark on your presentation that it's interesting that we focus so much on refugees and the first generation, although most of the social problems, for instance, crime, despite what all the right-wing media says, crime rates overall in first-generation immigrants are lower than in the host population, despite all that. But that doesn't apply necessarily to the second generation. We know that from the States and other research for 50 years. The second generation is much more of a problem, but less so in the public eye. So interventions for parenting support, for integrating in primary education, that may be in the long term much more important.
No, actually I agree with you, and that's what the studies from Norway that I presented were actually saying, that second generation are more at risk even to mental disorder, not only antisocial behavior. We tackled the issue of trauma and PTSD, and so probably it's necessary to differentiate what is trauma, which is a reaction to certain events that can be painful to various degrees and is a normal reaction to that event, from what is PTSD, which is actually a syndrome, so a mental disorder, post-traumatic stress disorder, extremely criticized, as you probably know, a lot of movements against. Symptomatology has been slightly changed in the new DSM-5 and will be also changed to be reduced to the essential, apparently, symptoms in the next WHO inventory of disabilities. Why do you think that much focus on PTSD? I have my theory, but I wanted to hear what is your opinion. Why, in the clinical world, in the organizational world, PTSD become the buzzword to understand the complexity of mental health for migrants?
That hasn't been always the case. Post-traumatic disorders in the widest sense have been around for more than 130 years, and they have been popular and they have been unpopular. They have become particularly popular after the Vietnam War in the States, and since then the role of the victim is a very, very strong one that is often linked with secondary gains. So if you have got proper PTSD, you can't be deported, for instance, in some countries, so there's these secondary gains. But it's not only blaming the victims, it's also attractive for psychology interventions. You have got something to deal with, something that also is interesting. There's some literature about how we are appealed, how we find it attractive to talk about the traumatic experiences of our patients. So there is almost a collusion on that, and also it makes it a bit simpler. You can say, okay, that's a problem. Here's something we do, although it's very questionable what we do. I mean, throughout psychological interventions are either that little effective or not effective. But there's only one exception that I'm aware of. That's detrimental. That's evidently detrimental, and that's debriefing after a traumatic event. So if you say, so every refugee should have first debriefing, that will be harmful. So I think the trick is to identify those who can benefit from or have that problem, who also can benefit, who are in a situation to where any improvement of therapy would make sense in their current situation. So if someone is afraid to be deported and knows without PTSD he might be more at risk, there's very little point in starting intensive treatment. But for others who are really held back, and those people do exist, of course, then to provide proper treatment.
Yes. Just then I wanted to to add something about NET, narrative exposure therapy, which you just presented. Randomized controlled trial hold in developed countries, a bit less in countries in development, where the practice is mainstream, but in a different way, with shorter trainings and so on. And there is an equal strong evidence regarding two other methods that are MDR, eye movement desensitization and reprocessing, and trauma-focused cognitive behavioral therapy. Somehow all the three have a wealth and are recognized now by WHO. That wasn't the case.
But not, they haven't been tested that for particularly for refugees. So the evidence for that is a bit weaker.
Yeah, they have been tested for refugees, maybe not in Europe. That's not throughout the path. Which brings us probably to the next question, which I think is quite important. I will take the second before the first. Let's say, how do you ensure continuity of care for mental health patients who are refugees and cross international borders? That is a bit what we are talking about, because these are the same people. So we cannot say there were no studies done, because there are studies done, even though they are not done in our centers of knowledge. And how do we ensure that continuity of care? I think that's very important for practitioners in the field.
Of course, I don't have an answer to that. When we did a study among healthcare practitioners, not just mental health, emergency department, general practitioners, and also mental health, about what they felt was one of the main problems in delivering care, it was the lack of any information, no access to medical records. They didn't know what had happened with a patient in the past. They didn't know the lab results of 5 years ago. They had to start from scratch, which is for the medics amongst you, it's not that easy if you don't know anything about the patient, then to get an appropriate picture. So, to what extent refugees can be provided with more information about themselves that they can take along, about at least a rudimentary medical record? I mean, that may be a way forward.
Yes. Just if I can add something to that, there was an instrument was tested, recently in Europe, jointly, with us, and WHO. It was a sort of passport, health passport for migrants. However, it became so we are still looking, into it and see if it's really effective. And also the issue that I think has to be raised is the one of confidentiality and privacy. In a way, this is something that has to be all of us are not really happy, if our medical records are passed from system to system without us knowing, and so what happens, to them. My suggestion would be that since you know that you are working with populations in transit, very often, or that are moving somewhere else, unless, you are lucky enough to live in England, where they arrive only few of them, and probably, they will stay for the rest of their life. So don't do anything that you think you cannot complete. So don't start care that cannot be completed in the time that you know or you presume you will be available for you. Don't do long-term trauma counseling on shore, starting it on shores. People are moving. And it's not only between countries, but it's between systems. In the sense that now we are facing this problem in Italy. Children who are identified as vulnerable at the shores are referred to identification center where they receive some kind of care, and then as soon as possible brought to residential center. In this passage, all the information is lost. Moreover, since when they arrive in residential center, their provider is not anymore the parallel system, but the official system in the country, so they will be referred to the health system, or the social system. Also, those don't know anything about, the child and what happened to them. So I think a need really exists to coordinate, as you were saying before, the various systems in terms of information, granting the agency of the migrant itself in terms of sharing experiences, and also, if I can say, don't do anything if you think you cannot bring it to conclusion. On the top of that, consider always, when you start doing something, what will happen next. That's a discussion that we have based to psychiatrists working in transit situations. When you prescribe drugs, are you sure that these drugs will be available for the same person afterward? No? Can they complete the cycle of treatment? Those are always issues that you have to take into consideration.
Again, it depends on the context.
Yes.
There are various contexts in which I think the issue doesn't arise. In detainment centers, for instance, you never know, at least in the UK, you never know whether you will see the patient again as a clinician. They can be deported tomorrow and you can't even say goodbye.
Exactly.
However, if large numbers arrive at the border in Serbia, which I already took as an example, that question doesn't arise. I mean, then it will be severe mental crisis. It will be severe depression, suicidality, psychosis that one has to deal with there and then.
Yes.
And it's a bit like, yes, emergency psychiatry, so long-term issues and arranging complicated psychological treatments. I think that's simply not on the agenda.
Yes. And the last question, and then probably we'll also look at what are the clustered, questions from the audience, is exactly about that. Emergency mental health care. I'm having this problem all the time with my teams all around Europe. So a person is identified with a severe mental disorder, brought to the psychiatrical clinic where, as you said before, there is no translation, but also the psychiatrist doesn't really understand the experience of the person that they have in front. In this sense, what you said about language is very, very important and interpretation. But also what you said about cultural awareness, that is not awareness of the different cultures. You don't have to have the little dictionary, that says, in this culture you dress like this, and then you don't touch, the person, because anyhow there are subcultures, there are individuals that are different, from the rest of the population. This to be very stigmatizing. But it's the training, that you can give to professionals themselves in order to be able to manage cultural diversity in health relations. What is the state of that in Europe? Because my sensation is that this is very easy to do, something that should be done, should be part of the official curriculum, for psychiatrists, psychologists, and general practitioners, doctors in general, but somehow is not there, unless you have other examples.
Yeah.
That you can do.
I mean, I'm not aware with all curricula all over Europe, but what I can see, you're absolutely right. It varies a lot. As I said earlier, to my knowledge, people are not routinely trained in how even to deal with interpreters. And then there are all these cultural competence trainings about which I'm in two minds. So it said that you don't shake hands with a Muslim woman. You can learn that, but they won't mind if otherwise you are genuinely interested. Or they will let you know what they expect from you. So I think it's in between doing possibly too much and nothing. But I think it would be a good initiative of the WHO to require the national bodies that are in charge of the curricula to say a little bit basic things should be incorporated.
I think so too. A very good example in this respect is the one of the Minkowska Center, in Paris, that really spent a lot of their, is a group of mental health professionals coming from different cultural backgrounds that spend a lot of their time training doctors in all the public services, in France, exactly in that, not how an Arab think or how an Asian think, but how can you make sense of what people are saying, acknowledging that you come from different cultural backgrounds, which is quite good. Severino wanted to say something.
Yes, Santino Severoni, WHO. Just to open the floor and to encourage colleagues to intervene also from here. A provocation to Stefan and one short question. So, very interesting discussion on the prevalence. We have seen numbers. Let's make a role playing. Let's imagine I'm a politician. Tomorrow I need to meet media, have a press conference, and I'm asking you to draft talking points. What is the message I'm supposed to give to the public? Refugees and migrant population do raise concern of increased mental health needs and services or not? That's the question, provocation. The other short intervention is that we are observing a peculiarity in these latest few years, latest movement of refugees and migrants, that we see a quite enormous quote of children, accompanied and non. Just Saturday, there was a ship landing in Palermo with 250 kids. It was called the children ship because they collected from all over the Mediterranean 250 kids just in a few hours. Those unaccompanied children, they are usually given a tutorship, so they're supposed to have access to any sort of care and services. Those with parents, of course, they have a different pathway, but still they're supposed to have a tutor, a parent, which is able to see if there is a need. What is your experience in terms of recording prevalence or alarming epidemiological situation in relation to children and mental health disorders?
Yeah. To the politician, I would say there is a problem if the numbers are large, as there is a problem to emergency departments and cardiology and everyone else. Of course, if there are suddenly large numbers of people on your doorsteps that weren't there before, then health service have to cope with, but not mental health service not more than others. With the children, I'm not aware of any good studies, but I think there's also a risk in that. Arriving on your own in Sicily as a child without your parents is quite a problem, and we should be careful not to put the problems, as we say in English, between their ears. It's not a mental health problem to start with. It's a terrible problem, and it is fate that all of us have a duty to avoid and to help them to cope with. But it's not that there's something wrong with them. I mean, that's also a question whether PTSD is seen as a disorder. Very often we tell the patient it's okay. After what you have been through, depending on what they've been through, it's okay to respond to that. What do you tell someone who has been through a concentration camp of 5 years and wakes up every night and says, oh, there's something wrong with you? Of course, they've come through terrible events. And with these children, again, if there are severe mental disorders, then yes, we have to cope with that. But don't please turn that problem into a psychiatric one.
Exactly. I totally agree with that, and also I wanted to say that that's why I think this tendency of having psychiatrists on the shores is good in the sense that they can respond to emergencies on the spot, but shouldn't become an early identification exercise. No? So if the person is clearly suicidal, clearly, especially children, clearly unable to function in the present moment, that's the moment to intervene, but they shouldn't do anamnesis, as some states, some countries are asking them to do, which risk to stigmatize these poor children even further from the very beginning of their arrival. There was another question from the floor.
I have a question. You said it's a big burden to the public health system that there's so many with mental health problems. But I used to work with UNHCR on the Greek islands.
Okay, I used to work with UNHCR on the Greek islands, and I've seen, because the legislation is like this, if you're vulnerable, also with mental health, you're sent to the mainland, and you can stay in Greece. So I've heard maybe from 100 people, 80 told us the exact same story. What do you make sure to protect the ones that are really traumatized and not the ones who are just telling the story?
That's a bit of a problem of the system, if you want, and then I will leave you the word. In the sense that if, in order to have your fundamental rights recognized, you have to show me that you are particularly vulnerable, then you will do that. And the issue is therefore a political one, to start with. Everyone should be granted essential rights, regardless, because they are refugees. They are not allowed, to come just because other reason, or because they are, medical evacuation, but because they have a right to be in the country. On the top of that, the issue is the one of proper, responses to everyone, so that's the other issue. So from one side, we shouldn't request them to be particularly vulnerable in order to access essential services. So the problem comes from our systems, I think. The second is good and well-prepared psychiatrists, clinical psychologists, that then, when the case is referred, will be able to discriminate between who has actually a problem that has to be followed up and who doesn't. So it's quite easy, straightforward.
When we founded the Institute of Psychotrauma in East London, we made it a principle that the therapist would never get involved in any detention issue. So we would never write a letter or for support or what have you. So that we would always keep our therapeutic role, because as soon as that is mixed up, you're not a therapist anymore. But it requires a lot of strength to stick to that.
Yes. And this is, if I may say, one of the issues of the problem with the trauma industry started at that point when a lot of practitioners, because in the UK, I'm making that example, PTSD was a reason good enough not to be deported, you know? So you had to complete your cycle of treatment. A lot of practitioners started to assign PTSD diagnosis on humanitarian grounds, no? So to be able to, to let the client stay a bit longer, maybe because he had another problem that wasn't recognized, so like this they could complete the cycle of treatment. However, this mechanism backfired because it created an emphasis on PTSD that wasn't, necessarily what the population was needing. Yes, and then maybe you can say your name. And,
yes, my name is Nana Wiedemann. I come from the Red Cross, from a resource center here in Copenhagen. Thank you for two very interesting presentations. I have one question or one thing that sparked my curiosity. I've never heard about the high likeliness of being schizophrenic in neither first or second generation refugees or migrants, and I'm kind of considering how can it be. I understand much better the PTSD, the anxiety and depression, but this is something I didn't know about.
Okay. I mean, there's endless literature on the rates of psychosis. Schizophrenia is one form of that in immigrants. And already since the 1930s, there has been literature showing that the rates can be higher, they can also be lower, depending on where people are from and where they go to. Now, if you have got those two groups, then overall rates will depend on how many studies have been done in which group, but they are basically meaningless. Of course, you are more interested in those groups in which the rates are higher. So the Afro-Caribbean in London, for instance, where the rates may be higher, there have been more studies. If you then put them together in a meta-analysis, you say, oh, it's higher. But it can be higher, it can be lower. That depends very much on the people. Explanations for that are difficult, and then I will stop. However, we don't know the reasons for psychosis in general. We don't know why the rates in inner city areas are 3 times as high than elsewhere. So as we don't know any of that, it's very difficult to come up with migration-specific explanations. But overall, of course, the number is relevant to services, but not on the population level, because psychosis is not that common.
And that's basically the answer. The numbers, the absolute numbers are minimal. So it's not, an epidemic of, or a pandemic of schizophrenia. Maybe we can take some questions from the audience, because there are a couple of very interesting ones. How to overcome administrative barriers of accessing healthcare services in general for migrants, refugees, and asylum seekers. Those are administrative barriers, not the one of language, culture, competence but the administrative ones. I don't know if you want
Politics and information. One is the politics to make it easy and to reduce them. The other one is information, both to those who want to use the services and to those who are in them and advise refugee groups.
The Covenant on Economic and Cultural Rights, and also the one on Basic Rights, state that healthcare is a fundamental right of everyone. And I think all of us as activists, professionals, should advocate for this really to happen. As I said, that's even in Europe, which is one of the best environments for this, is not really the case in many, many countries yet, especially for irregular, unregistered migrants. What is the role that community-based approaches to psychological support should play?
I'm not quite sure what's meant with community-based. If community-based is everything that happens outside the hospital, then of course it should be community-based. The hospital should be left to those who are absolutely in need of an crisis intervention. If it is meant something that's not office-based but of outreach, then, as I tried to explain earlier, refugees don't need any completely different type of service, but initially an outreach to bridge to services, to make the access easier. Yes, someone should go out into the community and help them with that. Maybe only for a limited period of time, but it should happen.
And we have always to be aware of the fact that communities in migration multiply. So what is the community-based? The host community-based, the migrant community-based, it becomes much more complicated, and that's something we have to Now I would like, instead of going on with those that are more or less chosen by the same number of people, I would leave the floor to Joseph, who have clustered, I think, questions per team, and so can tell us what are the main themes.
Yes, thank you very much, and thank you for the fascinating presentations. And I think it's a testament to the flurry of activity online as well, that there is a lot of interest in this. So just to give you a quick summary of the different questions, we're getting a lot through. So actually, it's linked to the first question that you took from the online set of questions around the cross-border issues, continuity of care. There is a lot of questions around countries of transit. How do you ensure that referrals happen, and how can you improve referrals between countries? Loss of follow-up comes up quite a lot, and also a question: are there any examples of effective follow-up for people on the move? And also a question related to this and cross-border issues and funding. Who picks up the bill? That's the question. So then there is a set of questions around unregistered, illegal, undocumented, irregular migrants. So how do you ensure that they don't fall through the cracks? And also a question specific to the London example that Professor Priba brought up about this. How did you promote services to unregistered or undocumented migrants? And then you've answered, or you've mentioned community-based approaches, community-based services. There was something about that. And also media. This is what comes up all the time. We had it in the last webinar. How do media shape reporting? How does reporting changes the mental health? How a mental health episode, reported in the media? How does it shape public health responses? And what could be done? So that's it from the online questions. You've got the main themes, and I would like to just say that we're releasing a poll. So those watching online, next to the questions tab, there is another tab where viewers can tell us about what they think about the webinar and how they like the presentations and so on. Thank you.
Cross-border, maybe we can start with cross-border. That's
I was just going to start with another one to get that out of the way, because if I started to discuss how we can stem the tide of the right-wing press, I would need mental health care myself. But I do think, as professionals, maybe more even as academics, we should be much more proactive in engaging with the public and informing on what we discussed today. And on that, the focus on PTSD is not very helpful either, because we present, again, the refugees as helpless victims who all need expensive psychological treatment, which is not true. So I think partly there's nothing for us to do, partly there's our obligation to be, I think, more vociferous than we are, and maybe lessen our self-interest as professionals, just promoting our own business. Irregular migrants, how should be funded? Again, that's a political issue, and depending on how you stand on that, you may congratulate the thousands and thousands of doctors across Europe who, according to our research, bypass the legislation and find ways of providing care somehow. But of course, that is a difficult situation and not sustainable for everyone in the long run. So I personally don't think you push anyone out of the country by denying health care. So but that's a political issue. Shall I stop here? Do you want to go on cross-border?
No, I think, maybe being the International Organization for Migration.
Proper follow-up is a problem within countries. Across borders, it's just a major problem. But I think that's step 4 to manage. And maybe the EC would have a possibility with a passport or so, maybe. But let's first get a proper follow-up in place at all. That applies, by the way, also to research. We didn't talk about research, and there will be no time. But what's desperately missing are long-term studies where we know what happens with people over many years, and not just evaluating a short-term intervention, brilliant, a bit better, but what happens really in the long run. So for the cross-border, I think that's still the future. But within systems, that of course depends on the documentation system you've got in a given system, which in some areas, a fragmented healthcare system like the Swiss or the German one is difficult anyway for anyone. In a state system like in Italy or England should be a bit easier.
Very, very briefly, we have only 2 minutes and a half. Cross-border is the main theme, I guess, because as we said, these people are transiting from one place to another. Usually, as I said, is empowering the person. So if the person is told that there is a problem and is told how the mechanism of referral can work in the countries where they intend to go, that's something they can do themselves once the legal provisions are there, and that's unfortunately the case. What we have to do is to fight so that everyone can have access to health and mental health care at all levels. The issue of cross-border, now we have, by instance, after many, many years, we are starting to have this done for refugees that from Lebanon are resettling to the UK. So for the first time ever, there is an exchange of information. So we do a mental health assessment in Lebanon, and this is transferred to the authorities in the UK, who will grant to persons who are considered more at risk access to the primary, to the easy access services, the new services in the UK, which I think is a best practice that could be duplicated also to other categories of refugees and migrants. For the media, I totally agree. And I would like to conclude with this. As we saw from the presentation, the prevalence of mental disorders among refugees and other migrants, apart from very specific populations like victims of trafficking, are not a pandemic, are not enormous numbers. But migrants have the right to mental health care as anyone else. Unfortunately, because of the political discourse on migration that tend to assimilate migration and vulnerability, migration and problems, migration and threats, the mental health discourse come a lot out. Either because these are people that, as I said, will bring problems because they are not mentally okay and they are traumatized and they will bring trauma to our society, or because we want to be nice. So we say, okay, no, but you cannot say to the migrants not to come because these are people that are suffering a lot. This is not helpful because it takes the agency of the people away, and the agency is the actual answer, to most of the problems. Even PTSD scholars will tell you that social support is the main solution, for PTSD. And somehow, as I keep on repeating for a long time, it's like if we are traumatized by the migrants, we have these reactions, of delusions, of unmotivated fears, of startled responses when a big group of them arrive at shores, and so on. And therefore, we want to read trauma in them to justify our own trauma, in relation to something that is questioning us as societies and as communities. And probably I would conclude with that. Thank you very much for the day. I think Santino wants to have a final word.
Join you in thanking you, both of you, for your very interesting contributions. We will keep working together. Actually, there was a very interesting proposal from one person in remote asking for WHO drafting guidelines for medical doctors.
Good idea.
Yeah. Exactly, to scale up multiculturality and better understanding of this topic, which is a very valuable point. So point taken and recorded. Thank you very much. Thank you again to the team, Joseph, Palmira, Simona, Edvik, hiding everywhere in the room, but without them, there would be no webinar. So please join me in an applaud to them.